Welcome to MedWing. Today I will talk to you about various aspects of stroke in the newborn. Neonatal stroke is stroke in newborns occurring between birth and 28 days of life. It occurs in as many as 1 in 2,500 full-term infants and even more. It is seen commonly in babies born prematurely. Sometimes stroke even occurs before birth. Most often, neonatal stroke is discovered shortly after birth in babies who are seizures or who are weak and unresponsive, and it is confirmed through neuroimaging. So, perinatal stroke is defined as an acute neurologic syndrome with chronic sequelae due to cerebral injury of vascular origin occurring between 20 weeks of gestation and 28 days of postnatal life. These disorders include focal cerebral injury due to arterial ischemic stroke, cerebral venous thrombosis, and primary intracerebral hemorrhage. Perinatal stroke is a common cause of acute neonatal encephalopathy. It may manifest as seizures, altered mental status, and sensory motor deficit. It is an important cause of chronic neurologic disability. Coming to the classification, as you can see, it is classified into two: acute perinatal stroke and presumed perinatal stroke. In acute perinatal stroke, the clinical presentation is that of an acute encephalopathy in the neonatal period, typically involving seizure and altered mental status, and less often a focal neurologic deficit on examination. In perceived perinatal stroke, the exact time of onset are inferred as perinatal, that is from birth to 28 days of life. It is based upon clinical and imaging findings. Clinically, it presents as chronic static focal neurologic deficit or seizures during the first year of life, in the absence of an acute neonatal encephalopathy. Imaging reveals remote arterial territory infection or periventricular venous infection. The major clinical anatomy subtypes is of four types: arterial ischemic stroke, hemorrhagic stroke, cerebral synovenous thrombosis, periventricular venous infection. In arterial ischemic stroke occurs when there is a blood clot or when there is a structural abnormality such as myomyema disease or other cerebral arteriopathies, or when there is a obstruction of blood flow within a baby's brain or spinal cord. Hemorrhagic stroke occurs as a result of bleeding in the brain. Common cause of hemorrhagic stroke include blood vessel abnormalities such as cavernous malformations, arteriovenous malformations, venous angioma, and aneurysm. Clotting disorders such as hemophilia, sickle cell disease, brain tumors, and congenital heart disease can also cause bleeds that lead to hemorrhagic stroke. There are also other conditions which are associated with an increased risk of neonatal stroke. These include sickle cell disease, cardiac disorders, and genetic conditions that increase blood clotting. Periventricular venous infection involves a focal, acute, or chronic infection in the periventricular white matter, not conforming to an arterial territory. It is often associated with evidence of germinal matrix hemorrhage. The annual incidence is 29 per 100,000 live births, or 1 per 3,500 for ischemic stroke. The overall incidence of neonatal hemorrhagic stroke was 1 in 6,300 live births, that is 16 per 100,000 live births. The most common symptom of neonatal stroke is seizures, often occurring as early as the first day after birth. The other signs and symptoms of neonatal stroke include hypotonia, that is extreme sleepiness and lethargy; hemiparesis, that is weakness on one side of the body; feeding difficulties; apnea, and infantile neurologic impairment. However, many babies don't show any noticeable symptoms of a stroke until they are older. There can be speech delays and balance difficulties, can be signs that a child had a stroke as a newborn. Clinical features of arterial ischemic stroke among infants with acute perinatal arterial ischemic stroke. The most common present clinical signs are seizures, altered mental status, and abnormal tone. Other signs may include hemiparesis and respiratory and feeding difficulties. Clinical features of cerebral synovenous thrombosis include seizures and alterations in consciousness. There can be symptoms mimicking idiopathic intracranial hypertension, including progressive headache, papilledema, and diplopia secondary to sixth cranial palsy, or with active focal deficit. Clinical features of hemorrhagic stroke include encephalopathy, seizures, hypotonia, focal weakness, apnea, or poor feeding. Periventricular hemorrhagic infection predominantly affects preterm infants. There can be vascular anomalies such as cavernous hemangiomas, atriovenous malformations, and aneurysms are rare causes of neonatal hemorrhagic stroke. Locations of atriovenous malformations include the vein of Galen, which is the most common site. The other locations include cerebral hemisphere, thalamus, and third ventricle, and choroid plexus. So when to suspect perinatal stroke? Perinatal stroke should be suspected in any newborn with signs and symptoms of encephalopathy, seizures, lethargy, apnea, or focal neural deficit, infants with hypotonia and feeding difficulties. Evaluation diagnosis is by neurovascular imaging. Diagnosis of perinatal stroke is confirmed by presence of one or more relevant ischemic or hemorrhagic brain lesions on neuroimaging that account for the clinical presentation. A cardiologic evaluation should be looked into for possible cardioembolic causes of stroke. A transcranial ultrasound assessment should be done to assess the blood flow in the brain. Genetic studies also should be looked into for hereditary risk factors for blood clots. As I said earlier, MRI is a preferred imaging modality. First MRI shows neonatal arterial ischemic stroke. The second one shows a neonatal cerebral synovial thrombosis. And the third MRI shows a neonatal hemorrhagic stroke. And the fourth MRI shows a arterial pursuant perinatal ischemic stroke. And the fifth MRI shows a periventricular venous infarct. And the sixth MRI shows a pursuant perinatal hemorrhagic stroke. Management is supportive, which involves treatment of underlying conditions and prevention of further injury. We should ensure adequate oxygenation and ventilation, control seizures, correct dehydration and anemia, monitor and correct metabolic disturbance including acidosis, hypoglycemia, hypocalcemia, and electrolyte disorder. Management of arterial ischemic stroke include seizure control and use of antithrombotic agents. Prognosis and conclusion. Maternal, prenatal, and perinatal causes are commonly associated, but most children incur. Recurrence can occur if there is a congenital heart disease with embolism or prothrombotic disorders, but most of them are idiopathic. There can be lifelong disability and hemiplegic cerebral palsy. There will be long-term epilepsy. The child can also have disorders of language learning, cognition, and behavior.